Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing health care to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Life After Stroke, presented by Dr. Prabhjot Khalsa, neurologist, and Maria Nunes, nurse practitioner with Washington Hospital Healthcare System. Our first presenter is Dr. Khalsa. Dr. Khalsa is a neurologist, neurointensivist, and co-medical director of the Washington Hospital Stroke Program. He has been with Washington Hospital for over 27 years. Dr. Khalsa is a member of the American Academy of Neurology. Now please welcome Dr. Khalsa.
Hello, I'm Dr. Khalsa, neurologist at Washington Hospital. Me and Maria Nunes will be discussing the topic of life after stroke. As you may be aware, stroke in the U.S. is the 5th leading cause of death. There are over 795,000 strokes every year in the U.S. Approximately 610,000 of these are first-time strokes. Approximately 1 in 4 of these occur in patients who've had a prior stroke. Approximately 87% of these are what we call ischemic strokes, meaning a blood vessel gets plugged and then causing a stroke in the brain. Others are what we call hemorrhagic strokes. Approximately 140,000 of the deaths, there are approximately 140,000 deaths from stroke every year. Stroke accounts for approximately 1 death every 4 minutes in the U.S. But the story doesn't end there. For some, it's just the beginning. Stroke is the leading cause of serious long-term disability in the U.S. Approximately 40% of the patients with stroke end up with moderate impairment. Approximately 15 to 30% end up with severe disability. Approximately 20% of the stroke survivors are institutionalized, so they end up in some sort of a long-term care facility. More than 4.5 million stroke survivors are living in the U.S. today. We measure stroke disability with a modified Rankin scale, as shown up below, where there's no symptoms. Patient has a modified Rankin score of 0, and it goes up as the disability increases. With regards to the domains of stroke recovery we'll be discussing today, there's the physical domain, which includes cognition and motor function, other functionality. There's the psychological domain, which includes self-concept and health perception, as well as the social domain, where there's a role change that happens in patient's life, and there's changes in patients' relationships with their loved ones. Post-stroke impairments include weakness or paralysis. It may include fatigue. Patients may present with impaired balance or coordination. Patients may present with pain and sensory symptoms. A lot of patients may end up with incontinence or what we call inattention or hemi-neglect. Patients may present with cognitive and visual impairments. Patients may present with swallowing difficulties as well as speech and language impairments. And most importantly, patients may end up with depression and anxiety symptomatology and difficulty recognizing their limitations. Disability is determined by the type and location of the stroke. It may go anywhere from no disability to severe paralysis. Strokes may be caused by blood clots in the blood vessels supplying the brain, or hemorrhages due to ruptured blood vessels in the brain. Patients with frontal lobe strokes may present with personality problems, problems with reasoning, problems with muscle movements, problems with speech. Patients with temporal lobe strokes may present with speech problems or short-term memory problems. Patients with parietal strokes may present with speech and sensory problems, and patients with occipital lobe strokes may present with visual impairments. As I mentioned, disability is determined by the type and location of stroke. So in patients who have right-sided strokes, that is, strokes involving the right side of the brain, they may be left with left-sided weakness, impulsive behavior, overconfidence in their abilities, as well as visual spatial problems. Patients with strokes involving the left side of the brain may end up with right-sided weakness, speech and language impairment, as well as slowing of behavior. In terms of disability after stroke, patients may present with weakness and paralysis if the stroke involves the frontal part of the brain. The weakness and paralysis may lead to spasticity and eventually contractures. Patients may present with impaired balance and coordination. They may have trouble sitting, standing, or walking. And the secondary complications from this may include dependence on others, feeling isolated and frustrated. They are at risk for falls, which may lead to injuries, and altered health, where patients would be at risk for developing pneumonias, blood clots, and pressure sores, secondary to the disability. Patients may present with disorders of sensation, where they may have numbness or pain on one side of the body. Usually these strokes involve the parietal lobe of the brain. Patients may present with impaired proprioception, where they have difficulty with awareness of where their limbs are in space. They may have impaired stereognosis, where they may have trouble recognizing objects by touch. They may have hemi-neglect, where they neglect the affected side of the body. These type of strokes lead to safety issues, including burns, falls, pressure sores, and infections. Patients may also develop swallowing difficulties after stroke. Approximately 40 to 70% of patients develop dysphagia, swallowing difficulty, within the first 3 days of a stroke. These patients are at significant risk of aspiration and associated aspiration pneumonia, which is the leading cause of death after an acute stroke. Swallowing difficulties may also place the patient at risk for malnutrition. Patients with strokes involving the left side of the brain may end up with impaired speech, which is called aphasia. They may have trouble comprehending what is said to them. They may have trouble expressing what they want to say. They may also have dysarthria, which is slurring of speech. Patients may develop with incontinence of bowel and bladder, usually bladder. Approximately 50% of the stroke patients will develop incontinence following the stroke, which decreases to 20% after approximately 6 months. This leads to embarrassment, leads to difficulty for family members and caregivers. It may lead to skin breakdown. Patients may require urinary catheters to treat the incontinence, which may lead to dangerous infections. Other disabilities may include cognitive impairment and visual impairment. Patients may present with impaired attention, impaired memory and social skills. They may have trouble thinking. They may have visual processing abilities or visual loss. Emotional changes due to the strokes may include depression, symptoms of anxiety, fatigue, impaired appetite, impaired sleep, as well as emotional lability, which is also known as pseudobulbar affect. Emotional problems and social deprivation may be due directly to the brain injury, i.e. the stroke. It may be secondary to the overwhelming sense of loss that they've developed because of the stroke. It may be secondary to the change in body image because of the stroke. their loss of independence. Since they become a bit dependent on others, they may feel depressed and anxious. They may also have an altered ability to communicate with their loved ones, which also leads to emotional difficulties. This also leads to isolation. So what is the answer? The answer is rehabilitation. Rehabilitation begins in the hospital immediately after the stroke. Patient is immediately assessed by physical therapy, occupational therapy, speech therapy, and the speech therapist will also assess swallowing and assist with improving their swallowing abilities. There are multiple options for rehabilitation once the acute hospitalization is over, which may include a long-term acute care facility. It may include skilled nursing facility-based subacute rehabilitation or outpatient rehabilitation or home rehabilitation, as well as self-rehabilitation, depending upon the severity of their deficits. Effective rehabilitation interventions initiated early after the stroke enhance the recovery process and minimize functional disability. Goals for rehabilitation include preventing recurrence, since 25% of strokes are repeat strokes. We need to manage comorbidities, including diabetes, high blood pressure, atrial fibrillation, high cholesterol. We also need to prevent complications of stroke, including pneumonias, blood clots in their legs, aspiration, skin breakdown, and safety is of utmost importance. An acute rehabilitation facility usually involves a 2 to 3 week stay where there is daily rehabilitation from morning to evening. The rehabilitation team may include physicians, nurses, physical therapists, occupational therapists, speech therapists, psychologists, a recreational therapist, as well as patient and family members and caregivers. The patient and family are the key members of the stroke rehabilitation team. The first 2 to 3 months following a stroke is the golden window of opportunity. Most of the recovery of function occurs within the first 2 to 3 months. It requires skilled healthcare professionals and requires the drive to work hard towards recovery. Acute rehabilitation requires at least 3 hours of intensive therapy a day for at least 5 to 7 days a week. Other options include home rehabilitation, where a rehabilitation specialist may visit patients' home, evaluate and make recommendations. They may work with the patient at home to help him rehabilitate, provide education, and encourage a lifelong plan for maintaining optimal function. Living with disabilities after a stroke is a lifelong challenge during which people continue to seek and find ways to compensate or adapt to persisting neurologic deficits. For many, the real work of recovery begins after the formal rehabilitation. We need to adapt the home environment to the stroke survivor in order to improve safety, accessibility, and independence. We need to remove dangers that patients may face when they're back at home. This may include handrails, non-slip shoes, placing the required items within their reach, providing ramps or modifications to furniture, and rearrange their environment so they're able to adapt to their home environment. And independence requires encouraging the stroke survivor to proceed with ongoing rehabilitation. Patient may require wheelchair, braces, walker, cane to assist with the ambulation. Continued goals for rehabilitation include increasing independence, improving cognitive and physical function, improving communication, maintaining safety, and achieving a satisfactory quality of life. And most importantly, preventing another stroke, since prevention is the best medicine. Patient and family need to be trained on spotting a stroke so that the stroke does not recur, and if it does recur, they're able to get the medical care they need. They need to be on the lookout for balance problems, eyesight changes, facial drooping, arm weakness, speech difficulty. If they notice any of these symptoms, it's time to call 911. Thank you. I will give the podium to Maria Nunes to proceed with the rest of the presentation. Thank you.
Thank you, Dr. Khalsa. And now our second presenter is Maria Nunes. Maria is the clinical manager of the Washington Hospital Stroke Program. Maria is a family nurse practitioner and is board certified in family practice. Maria has been with Washington Hospital for over 22 years and with the stroke program for the past 4 years. Please welcome Maria Nunes.
Thank you, Dr. Khalsa, for your insights on life after stroke. I am here to present on the pearls of wisdom on caregiving, which is caregivers are a vital role in the stroke survivor's life. As you can imagine, the stroke survivor has experienced a whirlwind. Suddenly has had this diagnosis laid upon them, has probably a realization of significant personal injury, has gone through many rapid responses, maybe calling an ambulance, going through the emergency rooms, perhaps was in an intensive care unit or on a stroke unit, has had multiple diagnostic tests, such as radiological tests, some lab tests, has also been through rehab in the hospital, as well as may have attended some acute rehab, and then is now at home. As you might recall that Dr. Khalsa mentioned that majority of the strokes are rehabbed at home. Which leads us into who takes care of the stroke survivors would be the caregiver. The caregiver is somebody that's helping a stroke survivor to continue living independently in the community, and it can be a very satisfying experience. But true enough, caregiver is not a role anybody really chooses. It seems to choose the caregiver because it emerges from the events and the circumstances which were beyond their control that have put them in this seat. Who might be the average caregiver? So typically a caregiver could be a parent, could be a child, could be a neighbor, a friend, a cousin, but typically it's always a spouse, and more than likely it's a woman, generally in the age group of 50s, 60s, or 70s, with significant health problems of their own. Understanding that caregiving can be a difficult job and requires a lot of patience, strength. You got to be resilient. You got to be committed. You have to be compassionate. And you have to use the resources that are available to you. So some facts about caregivers. As we all know that, as I said earlier, that caregiving is something someone has just got themselves into, not by choice. So typically, there is no formal education on caregiving. So they do get very minimal education and, of course, support. There's always that limited use of services, be it manpower or be it financial services. And as you can see, stroke survivors usually require a long term of caregiving. As I had mentioned, that typically a caregiver could be a spouse. So the fact that the caregiver is typically a spouse, it really changes dynamics, and we will see that in the following presentation. So let's look at some insights and what are the experiences and what we need to look at with caregiving. So the first insight I'd like to draw your attention to is experiencing profound sense of loss. So let's look at it from the stroke survivor's point of view and also from the caregiver. For the stroke survivor, that's truly a loss of independence. It could also be alteration in the marital partnership. It's something that they can't do things very easily like what they were able to do before. On the other hand, the caregiver has also lost their leisure time and their freedom. Truly, it's an alteration in the marital partnership. They have lost that ability to rely on their marital partner for physical and emotional support. There have been relationship adjustments. So pre-stroke, a marriage was partnership. After stroke, it becomes a caregiver-care receiver relationship. And these changes can be very upsetting and can produce stress. But I want to give a key point here that despite adjustments, we've always noticed that caregivers remain very committed to their loved ones and their partners. These are new responsibilities for the caregiver and also for the survivor. The caregiver has to maintain his former responsibilities. That could be, if it was a child, has to still maintain his responsibilities on household chores, taking care of their own kids and families, and now has to take on this full-time caregiving role and the responsibilities of the survivor. Well, the survivor could have been a family matriarch or patriarch, would be the breadwinner, could have been the decision maker, was controlling the finances, and now has to take a secondary role. So these are really new responsibilities that both the caregiver and the survivor have to get adjusted to. Next, the demands of caregiving. As you can tell, caregiving is a very hard work, and obviously, not everyone can get prepared for this role. The caregiver's health itself might be adversely affected. To begin with, as we had said, that these are generally in their 50s, 60s, 70s caregivers, they may have their own health issues. Also, there's always the sense of overwhelming. Besides, the survivor caregiver demands are so great that both are tied at home. Like I said, they may have a loss of freedom, and the feeling of social isolation creeps in. Having to depend on others, one of the insights. The survivor just depends on the caregiver, but the caregiver also depends on others for some respite because they do feel like they can't do this by themselves. They need to feel supported, so they have to look at some avenues outside besides themselves. And therefore, they have to embrace these new relationships for some good outcomes by staying in touch with others, your resources other than yourself. With all this, I would like to just give an insight on maintaining hope and optimism. I know we must maintain hope to improve function and overcome barriers. This improvement takes time. You have to overcome the feeling of stress and guilt and fears about this new role so that you can have some good functional outcomes. Some of the resources I'd like to direct your attention to would be the American Stroke Association and the National Stroke Association. But in our backyard itself, we have the Washington Hospital Stroke Program. I am the clinical manager, and I'm happy to help and connect you with any of the resources that you would require. Besides that, we also have some top caregiving resources that are able to empower caregivers, like the AARP, the National Institute of Aging, the Family Caregiving, to name a few. I'd like to say these final words for the caregiver, said by Dana Reeve, who was a caregiver herself. Rule number 1 for all caregivers is to take care of yourself. The more in balance you keep your own well-being, the more you will enhance your coping skills and stamina. And these are, to recap, the pearls of wisdom for the stroke survivor. You got to make the most of the day. You can't go back into the past, into yesterday. You've got to move forward. You got to look forward. You can enjoy your leisure activities. You just have to adapt to the new changes. You got to realize that you can do things before stroke. You just need to learn how to do it in a new way. Like, you will be able to ride a bike, just an adaptive bike. Go out with your friends. You got to start slow, pick up the pace, and then maybe aim for the stars. There is life after stroke, just in a different way. Maybe if you golfed, you've got to do adaptive golf. And the stroke survivor, I just want to say this, has gone through a whirlwind, has gone through this new diagnosis, has been through the hospital, has had rehab. If you could do that, you could do anything. And a final word by this famous artist, Carol is, this is for the survivor. Realizing my humanity, letting go of whether or not I am right or wrong, in control or not. I must learn to accept this life for what it is and find faith from within, no matter how my broken insides revealed otherwise. Thank you for your attention, and we will take any questions now.
Thank you, Maria. We'll have Dr. Khalsa join you as well. So our first question is, how long does it take to recover from a stroke?
The initial improvement in disability after a stroke usually occurs within the first few months. But ongoing improvement may take up to a year to get at least 80 to 90% of the improvement. But depending upon how hard the patient or the stroke survivor works, improvement may continue for years to come.
Okay, thank you. And our next question is, I am a caregiver for my mom. I need a break. Are there resources to help me?
Yes. As I mentioned in the presentation, we do have the American Stroke Association. We do have AARP. You do have family care services. But we also have Washington Hospital Stroke Program, where you can call the hospital and ask for the stroke program, and I'm happy to connect you with resources.
Okay, and our next question is, are there screenings for stroke risk?
As we discussed before, the stroke risks include high blood pressure, diabetes, high cholesterol, smoking, alcohol. So the most important thing anyone who thinks they may be at risk for stroke to do is to go see their primary care doctor and be evaluated for any underlying medical problems they may have. So the medical doctor can order blood tests and other tests to assess the risks for stroke.
And our last question, who can join the Washington Hospital Stroke Program?
Yes, anybody in the community can join the Washington Hospital Stroke Program. You need not have to be a patient over here at Washington Hospital. Anyone in the community is very welcome to join the program.
Thank you. And this does conclude our program. Thank you, Dr. Khalsa and Maria, for this insightful presentation, and thank you for your time today to deliver this to us. And thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.